Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 222 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, JMP, a 34-year-old woman in Zambia presented with symptoms of pulmonary tuberculosis. JMP consented to have HIV testing, and was found to have infection with HIV-1. JMP was started on quadruple therapy for tuberculosis as per WHO guidelines, following which she was started on combination antiretroviral therapy. Randomized controlled trials in Africa have shown a substantial reduction in mortality in patients with HIV-associated TB with prophylaxis with what drug? Is it with A. Atovaquone, or B. azithromycin, or C. clindamycin, or D. dapsone, or is it with E. trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. trimethoprim sulfamethoxazole. I will clarify why. Routine administration of TMPS-MX in patients with HIV-associated TB was shown to have a substantial reduction in mortality in the pre-HART era in sub-Saharan Africa, and the effect has been maintained with widespread ARV use. Implementation of this is improving steadily. Please proceed to the next question. And the next question reads, ZPL, a 27-year-old man from Uganda presented with fever, back pain and weight loss for several weeks. There was no weakness in the lower limbs nor any bladder symptoms. An MRI was performed. ZPL was found to have osteomyelitis of L4 and a left-sided paravertebral abscess communicating with a PSOAS abscess. CT-guided percutaneous aspiration was performed and samples sent for microbiology. Investigations are done and the results are as follows. Microscopy: moderate pus cells seen. Gram stain was negative. Moderate acid-fast bacilli seen. HIV-AGAB positive. CD4 absolute was 175 per microliter. CD4 percentage was 13%. ZPL required treatment with combined antiretroviral therapy and antituberculous therapy, but his clinicians were concerned about TB iris. So my question to you is, what is the most appropriate strategy? Is it A. Start both combination ART and quadruple TB therapy immediately? Or B. Start combination ART immediately, await mycobacterial identification before starting quadruple tuberculous treatment? Or C. Start quadruple therapy immediately, start combination ART at 8 weeks? Or D. Start quadruple therapy immediately, start combination ART when repeat samples are culture negative for TB? Or is it E. Start quadruple therapy immediately, start combination ART within 2 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Start quadruple therapy immediately, start combination ART at 8 weeks. I will explain why. The risk of opportunistic infections is balanced against the additive risk of drug toxicities and of TB iris. There is a survival benefit associated with concurrent administration of TB and HIV treatment, and WHO advice is to give both regardless of CD4 count. Mortality is further reduced in those with a CD4 below 50 per microliter if combination ART is started within 2 weeks. However, those with a higher CD4 count can benefit from a later introduction of combination ART between 2 and 8 weeks by the reduction in TB iris. Please advance to the next question. And the next question reads, CZS, a 52-year-old MSM was started on combination ART with efavirenz, tenofovir and emtricitabine. CZS tolerated the introduction well and achieved viral suppression by 16 weeks. CZS was given an accelerated course of hepatitis B vaccination combined with hepatitis A. His baseline serology showed measles IG, G-positive, toxoplasma IG, G-positive, varicella IG, G-positive, syphilis EI negative. 5 months after starting combination ART, CZS attended the walk-in clinic as he had noticed new lesions on his feet and neck. See photograph. He had also developed dyspnea on exertion, orthopnea and right-sided pleuritic chest pain. On examination, CZS's temperature was 36.9 degrees Celsius. His heart rate was regular at 88 beats per minute, and his respiratory rate 16 was at rest. His oxygen saturations were 95% on room air. Chest examination was consistent with a large right-sided pleural effusion. Pause the video and carefully scrutinize the photo before answering the question. Following skin biopsy, a diagnosis of Kaposi's sarcoma was made. So my question to you is, what is the most appropriate treatment strategy for CZS? Is it A. interferon alpha-2A? Or B. paclitaxel? Or C. pegylated liposomal doxorubicin? Or D. rituximab? Or is it E. vinblastine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. pegylated liposomal doxorubicin. I will explain why. Doxorubicin given as calyx or Doxil is the treatment of choice. Please progress to the next question. And the next question reads, WOA, a 45-year-old male patient presented with fever, weight loss, hepatomegaly, ascites and papular-nodular skin lesions. WOA was HIV positive but had stopped antiretrovirals 3 years previously after poor adherence and intermittent clinic attendance. The lesions had developed from small red papules into large friable nodules, which easily bled on minimal trauma, as shown in the photograph in the next slide. A skin biopsy was arranged. Pause the video and carefully scrutinize the photo before answering the question in the next slide. So my question to you is, what stain is most likely to confirm the diagnosis? Is it A. Hemza, or B. iron hematoxylin, or C. methenamine silver, or D. Warthenstari, or is it E. Ziel-Nielsen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Warthenstari. I will clarify why. The Warthenstari stain is the diagnostic stain for demonstrating Bartonella organisms within a biopsy specimen. Please advance to the next question. And the next question reads, PBO, a 48-year-old woman known to the HIV clinic developed large, recurrent, painful ulcers in her mouth, as shown in the photograph below. Pause the video and carefully scrutinize the photo before progressing to the next slide. Continuous eruptions persisted over several months. PBO tried topical and systemic steroids with no response. So my question to you is, what other systemic treatment may be beneficial for refractory disease? Is it A. acyclovir, or B. fluconazole, or C. methotrexate, or D. thalidomide, or is it E. vitamin B12? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. thalidomide. I will explain why. Trial data show that thalidomide is an effective treatment for aphthous ulceration of the mouth and oropharynx in patients with HIV infection. Caution must be taken due to its teratogenicity. Please progress to the next question. And the next question reads, GSO, a 24-year-old primigravida presented at her 12/40 booking appointment and disclosed that she had HIV-1 infection. GSO had been taking tenofovir, emtricitabine and efavirenz for 3 years. GSO's last CD4 count was 345 cells per microliter. Her HIV viral load was less than 50 copies per milliliter. She had occasional blips, and no low-level viremia since. Viral suppression was achieved. Archived mutations are M41L. So my question to you is, what is the most appropriate advice with regards to antiretrovirals? Is it A. Add raltegravir to intensify her regimen? Or B. Change efavirenz to atazanavir boosted with ritonavir? Or C. Change efavirenz to nevirapine? Or D. Change tenofovir emtricitabine to zidovudine plus lamivudine? Or E. Continue current regimen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Continue current regimen. I will explain why. There is no evidence to date of increased birth defects associated with efavirenz, although there are animal studies that show teratogenicity. Advice is that efavirenz may be continued if a patient is already established on it. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 223.